Record. Okay. Hi, my name's Alicia, and I have this presentation, and it's going to be called Empowering LGBTQIA plus Veterans of Color, Advocating for Culturally Responsive Mental Health Care. This is very important, and it needs to be discussed, especially in our political climate. So without further ado, let's get started. Okay. So this is just kind of my table of contents. We're going to talk about my reason behind this topic, understanding the identities of the letters within LGBTQIA+, intersectionality, and some research questions that kind of help me to conceptualize this research. We're going to discuss some of the methods attached to this, and we are going to touch on military sexual trauma because it is a reoccurring um, controversy that does have a long, enduring history within our military. We're going to be talking about racism in our mental health care systems and some key themes within our participants, within the veteran population, and some disparities in the PTSD treatment access, and some shifts in the demographics um, during the progression between the earlier times of record within the military versus now, and some coping strategies and some resources. So let's keep going. Okay, there we go. So, introduction and purpose. LGBTQIA veterans do face a layered systemic barrier within mental health care and accessing it. Um, they end up having unique circumstances because of their identities. Um, Not only do they face criticism based on the idea of it being a choice, on who they are attracted to, and who they identify as. But the color of their skin is also up for discrimination too. And it all plays a role in how they are treated within the military. Um, so that's where we talk about intersections. So the stigmas and the focus on the PTSD, that post-traumatic stress disorder, military sexual trauma are things that people that have these identities are coming across and experiencing, unfortunately. And so the goal of this presentation is to not only inform and inspire, but to kind of enact some kind of inspiration and some participation in talking about this and getting some movement and changing the system because we can't stop talking about it. If we do, nothing happens, and the trauma continues, the brutality continues, the violence and abuse continues. So we need more people talking and policymakers acting. So, understanding LGBTQIA plus identities. So the L stands for lesbian, the G stands for being gay, B is bisexual, T is transgender. Q can mean queer or questioning. The I is intersex. A can be asexual or agender. And the plus kind of incorporates more that are not already in the L through A categories. But I wanted to include it on the slides. Two-spirit, non-binary, gender non-conforming, and pansexual. So a thing that people may get misconstrued is sexual orientation is the same as gender identity, and they're not the same. And it's essential to know um, that all of these all of these identities are important to highlight because one is not more important than the other. Um, and if we are considering what's going on currently within our military, trans folks are kind of being targeted, and they are being forced out of the military, and treatment plans to kind of help with those surgeries um, with surgical treatment for their private areas, um, they are not being paid for anymore. So a rejection to, their rights and their needs are more and more being seen. So it's a big problem, a big controversy. And then the military has a history of don't ask, don't tell. Um, it's a way of just keeping things under the carpet and behind closed doors, the abuse. Um, it would happen where people found out someone's identity and would abuse them. And it looks in many ways like sexual abuse or just being abusive physically, mentally, verbally, making someone's life be put in danger and not talking about it, being forced to keep quiet about it. Otherwise, the person who's a victim gets in trouble, or gets put out of the military. So um, that there's been a law that took care of, or at least has been trying to implement more attention to the abuse. And so to go back to sexual orientation, what that is who you're romantically or sexually attracted to, whereas gender identity is your internal sense of being, whether that be female, male, both, neither, or something completely different, a separate gender altogether. And it's always good to remember that these identities exist on a spectrum. So let's move on. Okay, so my screen's kind of in the way, but this says intersectionality at the core. So this term, intersectionality, was coined by Kimberly Crenshaw in 1989. And intersectionality helps us to see the full person. Um, a Black trans woman veteran will experience systems differently than a white gay man, or a cis Black male veteran, unfortunately. And so this slide kind of details the rest of the presentation, which is just talking about how we can't really treat identity in isolation. You have to look at the entire person, be holistic with your approach. Um, and so, intersectionality was introduced because Black people were being failed by the legal system, Black women in particular. Um, they couldn't bring a claim that Black women or women and Black people are at a heavier disadvantage, if, they share those identities. They just kind of focused on either one, being a Black person or being a woman, only one at a time. And it makes it kind of it's kind of a problem. It's kind of a hard thing to to solve, to prove when you're in a court case, um, that these identities are kind of impacting you. And especially if the court system has discriminatory views towards both of those identities. So this kind of brings to our attention how intersectionality translates to LGBTQIA plus, BIPOC, and our veterans. because of these unique traumatic and systemic neglects that this population endures. Because the systems don't always see them as a whole person, unfortunately. Let's keep on moving. So this slide's talking about my research questions and um, class discussion. Um, so what mental health challenges are specific to LGBTQIA plus veterans of color? And I'll answer that. Higher rates of post-traumatic stress disorder, depression, military sexual trauma, identity-based trauma and stress, and systemic distrust. All of those are some heavy challenges that this population faces. The second one, how do they perceive PTSD treatment options? Um, what I found was that veterans see this as limited, seeing PTSD treatment options as limited, um, culturally unresponsive, and often inaccessible or invalidating. So having a competence, like a clinician having a grounded foundation within having a multicultural framework, knowing that clients who come from backgrounds as people of color is very important for clients to feel seen and validated. And if that's not happening and are just being diagnosed as, folks who have been in some traumatic situations and are just getting the diagnosis, need to be put on medication, and not really being seen as a person, and also not getting those experiences, put in a well, how do you say this? They're not being understood as a person and as a unique situation, that they've been placed in. It can be really hard to trust them. So, um, I that's what I found from looking at the research that's already been made. And my last question was, what prevents veterans from accessing services? And it might seem obvious, but I did think that this was important to say that what prevents veterans from accessing services is the stigma, um, racism, gender-based discrimination, provider bias, and lack of affirming care. Um, Mental health service and, self-care and all of these really great strategies to taking care of self are not new phenomenons, but they are being talked about more frequently nowadays than they were in the past couple of decades, which is great, but that can't really help for folks who endured a lot of trauma in the past, who were going in the military service in the 90s, in the 80s, in the 70s, 60s, um, and prior to that. So, how are they going about their lives currently who share these identities? Um, Probably not so great, because those symptoms have not yet been addressed. And generational trauma is a real thing that goes from one generation to the next generation. And we aren't taking care of ourselves. So then that kind of transitions into who we bring into the world, also sharing those same habits of not taking care of self and wondering what's going on, feeling a lot of stress, a lot of pressure, um, building up. So I have a video, but we're going to keep the videos out of this presentation for this time. But these are the questions that I kind of saw that were gaps within the literature for this population. Um, and these are also reflected in the lived experiences of, the veteran population. And I'm hoping that folks that watch this are really taking some time to reflect and see who you whatever your role is, if you're a student, if you're an educator, an advocate, policymaker, provider, how you can shape someone's experience with being vulnerable and allowing for someone else to share vulnerability with you. And I'm also inviting you to kind of search within yourself and kind of see what your identities are and see how you show up when you are vulnerable. And how might that differ when someone is holding multiple marginalized identities? And let's keep going. So, methodology, I looked into a dissertation study. Um, and within that study, they use this approach called group concept mapping, and it combines qualitative sorting with statistical analysis, where participants, veterans, generate and sort and cluster their own statements. And within those statements, only 36% of the veterans had suicidal ideation, um, and had access to care. So PTSD remission rates were 0.35, and those were for Black people, and 0.15 for Latino veterans. And then the participants were primarily college-aged, LGBTQIA plus BIPOC veterans. And I found within the NHIS 2022 article, the findings um, were found within the dissertation. The dissertation used the article's findings as well. And it was called Conceptualizing the Healthcare Experiences of LGBTQIA plus veterans, if anybody wanted to look that up. Okay, so let's talk a little bit about military sexual trauma. So this is what military sexual trauma is. Um, Sexual assault or repeated sexual harassment during military service. Um, and people may assume that this happens only to women, and that is not the case at all. This happens to men, and um, it's often in silence that people don't, that men go through this, women as well. There's a shame attached to the victims experiencing abuse and not so much the abusers. And not, don't get me started on the masculinity norms that kind of flow within the military regulations. Um, it kind of, MST, it fractures your trust, and it traumatizes the survivors time and time again, when you're re-engaging with this system, with any system, especially at veteran affair clinics. It can be really difficult, going back and talking about what was experienced as a victim, as a survivor, of sexual abuse. So, um, and we can also bring to your awareness that it's disproportionately experienced by LGBTQIA plus BIPOC people and women. And so eh, it's linked to PTSD, depression, and suicidality. Um, it impacts all genders again, and I want to include non-binary service members as well. Um, and it's often underreported due to the fear of retaliation, that shame component that I mentioned, and a lack of affirming support. The don't ask, don't tell, unfortunately, does still have a pervasive um, flow. Um, it's subtle, even though um, the military has said to have done away with that that uh, that rule. but people still kind of hold it close and utilize it to continue the abuse. So, um, yeah. Racism in mental health systems. Um, so bias in diagnoses and treatment recommendations. This isn't new. This has been a thing of the past and of the current. Um, Lack of racially and culturally matched providers. People like to see people that look like them giving them service, and it makes sense. Um, there's just a familiarity that provides comfort to clients or to patients receiving care, seeing someone that looks similar to them, and having more people of different backgrounds and different diversity, um, just more culture involved in healthcare provides this. And there's severe lack of diversity within our healthcare system. And then there's experiences of microaggression, so the tone policing, saying that someone may be too loud or just how they say things is a problem. Um, Assumptions about education, misperceiving that someone doesn't have education because of how they speak, misidentifying um, slang, maybe usage, and having someone change the way they talk or like force them to conform to these systemic ways of speech because of that being the norm rather than accepting that they come from some place that uses a different way of speaking. And that's what they're comfortable with. Assumptions about education, dismissal of emotional pain. An example is when Black women say they're in pain when they're giving childbirth and they are dismissed and not given any kind of epidural or given any kind of medication to help ease that pain because they're seen as having very high pain tolerance, when in reality they're more likely to die because of medical neglect. And that's been an issue that's been getting more highlight in news. But yeah, all of these components often lead to the distrust and underutilization and disengagement from treatment. But this treatment is very necessary. So it's up to medical providers and just people who give service to people needing mental health care to go through training to do better, to know what those clients, those veterans, those survivors need to feel safe in those hospitals, in those sessions, those clinics, those rooms. Because holding space for someone who's been through traumatic situations is vital for trust to be gained, along with um, just holding more security for reducing suicidal ideation. Um, and then the historical mistrust. I gave some examples like the Tuskegee experiment, like with syphilis, the VA disparities, um, microaggressions within care. So like misgendering, if someone tells someone their pronouns and they keep getting told the wrong pronouns, that's misgendering too. Being dismissive of someone's concerns, racial invalidation, lack of culturally affirming providers. We touched on that a little bit earlier. And then, of course, just like a little bit of a combination of racism and then homophobia, equaling up to double stigma, leading to care avoidance. Just thinking that people can just learn how to deal with all of the trauma that they've endured because it's better than having to go through more trauma to receive care. You can't really blame people for wanting to take care of themselves because it's just seemingly not going to be addressed. Going to these places that say they give care, but only really seemingly give care to one particular type of population. And in question, the population in question is white, European passing, or, men and cisgender folks. So let's move on. This is also talking more about that. Um, Representation is lagging in media and storytelling. Narratives often center white, cisgender gay men. BIPOC, trans, and non-binary veterans are underrepresented or erased. I'm glad I actually put that in here, uh, because, it's great to say that like we've come a long way in terms of, who is serving, but it's just not seeming like we've made much progress in how these stories are being told. When we hear about queer veterans, it's often about the white man's journey, and it's just, we can't keep calling that a coincidence. There seems to be some erasure happening with people of color's stories. Um, and it's a result of who is holding the power within the media, um, and then publishing, along with who's holding policy or who's in the spaces of policy. So we need more stories coming from people of color and people who are queer. Um, we need more stories from disabled veterans, and not as exceptions, but as part of the full truth. Yeah. And now we're going to talk about some shifts in veteran demographics over time. So, I wanted us to kind of focus starting from World War II, to post 9/11, which is the era that we're currently in. We've got more inclusion of women, BIPOC, LGBTQIA plus. We've got some increased mental health needs due to multiple deployments and identity conflict. Um, can't say that's great, but um, and systems are slow to evolve, and inclusivity and trauma-informed care, which is all we've been talking about this whole time. And diversity in our military is not a new concept. In fact, it only kind of helped with the strength of our military, and how that looks is diverse perspectives with enhancing the strategy of our military, inclusive foster or inclusion within fostering units of morale and building trust, reflecting modern values of equity and justice. And then inclusion is an evolution, not a threat, benefiting ultimately everybody. Um, we operate with greater integrity. So, um, we have to kind of show that we support people of color and folks of different identities, so that when times like this, where we're seeing people of color and seeing trans folks in a situation of being forced out of their jobs and their careers, um, unfairly, now is the time to speak up and show that we care about them, and not just stay silent, because when something starts to happen to one of us, it's a problem for all of us. Um, so lastly, I just wanted to talk about some coping strategies and resources. Um, we got some narrative therapy, somatic body-based approaches, mindfulness-based stress reduction. There was a lot of discussion within research talking about how focusing on breathing, inhale and exhale, does help with, excuse me, it does help with kind of calming your brain, along with centering your focus back to reality, and taking away the past trauma little by little, instead of like avoiding the suffering. And that does help when in the care of a therapist, a clinician who's been trained. Um, And along with that is peer support groups, LGBTQIA plus veteran meetups, and veteran centers. Um, just places where people can talk about these situations that they've endured, talk about their experience serving, with people who have that similar experience and can share what helped them or kind of um, collaborate on what can be done in support of finding out how to do more for each other. Um, and then, of course, culturally affirming therapy. There is Open Path. There is Therapy for Black Girls. That's a website, along with inclusive VA services. Um, there are some skills like, again, with mindfulness, narrative therapy, body-based trauma work, and some hotlines and applications. We've got the Veterans Crisis Line, Trans Lifeline, and the Trevor Project. Those are all very inclusive and very pointed towards giving resources towards like housing, towards funding, and just more access to care. Along with that is just like having apps like Pride Counseling and My3. And with that, these strategies are not just helpful, they are life sustaining. Um, and as future clinicians, as educators, and as allies, we should know where to refer and how to support because again, this is our issue too, even if we're not a part of this community within BIPOC and within LGBTQIA plus veterans. So thank you so much for watching my video. And I hope that I was able to teach you some new information and get you started on this journey toward more education. Thank you.